Utopias, and today's technologies hosted by Johannes, bringing a global conversation discussing technologies that affect us all.
Hello and welcome. My name is Johannes, and I'm the host of this show. Today I'm here with Claudia Pagliari, and we will be speaking about a number of issues connected to the healthcare innovation that has been recently, healthcare innovation and also information technology innovation that is connected to the healthcare innovations. That includes also the Internet of Bodies, that includes such ideas as brain implants or connections with the brain to computer interfaces. So let me introduce to you Claudia Pagliari. She's a senior researcher, educator, and consultant in digital health based at the University of Edinburgh's Medical School. Director, eHealth Interdisciplinary Research Group and MSc, Masters in Science in Global eHealth. Co-founder, theme leader of the NHS Digital Academy, digital ethics advisor to Scottish Government, member of World Health Organization roster of experts in digital health, fellow of the Royal College of Physicians of Edinburgh, multi-sector transdisciplinary expertise she has in the study of emerging digital and data innovations, particularly but not exclusively in healthcare. That includes program evaluations, controlled trials, qualitative studies, social and policy research, user-centered design and engagement, horizon scanning, and evidence synthesis. Strong interests of hers are in the digital data ethics and user-centered design and engagement area, horizon scanning, and evidence synthesis. She has strong interest in digital data ethics and ICT for good governance, currently researching digital responses to COVID-19, including contact tracing apps, big data infrastructures, and tackling the infodemic, something we also hopefully will be speaking about. She's also interested in robots, AI, blockchain, e-government, workforce informatics, biometrics, consumer genetics, social media, and related issues in digital trust, privacy, and accountability. She's an expert reviewer for EU international research organizations and a co-editor of PLOS Digital Health, JMIR Medical Informatics, and a member of the British Institute of Management, British Computer Society, Royal Society of Medicine. And she's an experienced keynote speaker, author, and social media commentator. Welcome, Claudia, and let's get right into it. Could I just ask you right away about, I think one thing that really interests me is these processes, the innovative processes that are intertwined. For example, the advances in medical treatments in general, and how they might be working with advances in the information space, and then also how regulation processes are catching up with them, and how ethical thinking and governance is evolving or co-evolving with these innovation processes. Could you speak something to that?
Certainly. I think historically there's been a slight mismatch between innovation in medicine and innovation in technology space. And when I say technology, I mean more computer-based technologies. But they are gradually coming together. So in the past we had focus on medical innovation was very much focused on things like surgical equipment, medicines, and so forth. And it was quite an enclosed environment. We were obviously also seeing other developments outside in robotics and so on. But they are coming together more closely, even as we see not just the use of digital technologies to deliver services, for example, through telemedicine, but also in some of the fundamental ways in which we create medical knowledge or medical products and services. So, for example, the use of deep learning in drug development, for example, or in certain types of genomics. So really they're becoming codependent, not only medicine, but also public health. Because public health has always been about large populations. It's always been about kind of understanding trends and trying to identify groups in need of intervention, trying to shape the sorts of interventions that you use to reach people. And again, this has been gradually over time enabled by the development of data platforms where large amounts of information about populations, retrospective and real-time data, can be used to produce predictions as well as looking at trends. So essentially, public health itself is becoming a data science, or is indeed to a large extent, and that also relates to health policy, which is increasingly informed by these sorts of systems and the dashboards and the tools that go alongside them. So we're seeing these codependencies developing. The other thing, though, to bear in mind, though, is, of course, in medicine and clinical practice, things have been more tightly regulated, and the ethical frameworks have been very clear for many, many years. And there's a good reason for that, because, health is fundamental to your, life. It can have impacts not only on your longevity, but your family relationships, your work. So there's lots of ways in which we need to absolutely make sure that people are safe when they receive intervention. So innovations and the regulations around that were very focused on patient safety. But increasingly, there's also this move, it's always been the case, but as we are dealing with more and more data, the considerations come down to data privacy as well. So, not only because it's embarrassing that certain things are seen, but also because other people could, if your data were available to other people, could start to make predictions about your future that you may not be aware of yourself. And this could potentially impact your choices and create unfairness. So, in the sense, all of this consideration around data and digital privacy and data ethics is converging with medical privacy and ethics, but in a slightly different way to the more traditional one, which had to do with your relationship with your doctor.
So this medical privacy, there I had a question, because I've seen that recently Sir Berners has contracted with the NHS, and I'm interested in, and I think it is around his project on Solid, which is a quite interesting new way of reshaping the internet as a whole. And I guess I would have a lot of repercussions also in the medical area. Are you aware of this, and what do you think of this? Is this a special thing that we should all be aware of, or is it just a small project, or is that something? Is this a major directional shift toward a Web3 environment where Sir Berners is a very different one from, let's say, the blockchain one, for example, because it's actually distributed in different ways, right? So if you have data in these pods, as Sir Berners suggests, then the data is owned by the person to whom it belongs or whom it is attached to. So if I, just to explain this really quickly to the audience, right? So if there's data like my name, my social security number in America would be a social security number, here would be something else. But all of this sensitive information, but also public information, would all be stored in one place, and I would then have the possibility to give various online platforms access to my data from this one central pod. So Facebook could see my face, my photograph of my face, my name, when I was born, maybe, and so on. And I can give other kinds of things to LinkedIn, allow. And so that would be, the data would still be distributed, but each person would have, so it would be distributed differently from the blockchain version, which is that every computer has copies of everyone's data on it. In this case, every computer only has copies of one person's data, namely the person who owns the computer, and also they owns the data, therefore. And then, but the data of the whole population would be distributed across these pods, and then federated learning and such things could be used to basically learn everything about these people without learning anything about their identity. Is that something that's in the works? Is this going to be a fundamental shift? What do you think of that?
Well, I think it's a very interesting and good set of proposals. I think, there's so many issues there to unpack. It's quite important to think about what it is we're speaking about. On the one hand, we have Tim Berners-Lee's sort of long-standing, more egalitarian view of an open internet, and he's railed against the, particularly corporate control of people's information and so on. So he's sort of motivated to put control back in people's hands, and has considered these aspects of more personal data stores for many years, as have others. But I think this is a kind of new concept. It's just taking distributed computing and distributed data management to a different level for two reasons. Well, there's a number of reasons, actually. Firstly, the NHS is interested because it has, like many massive, complex organizations, big interoperability problems. Big problems when it comes to trying to get information to move successfully from one place to another, partly because of those privacy concerns and the governance procedures, and partly just because the technologies are clunky. And this can sometimes be a barrier to care when you are waiting for the machine to pump the information through and go through all the gates. And one idea is that clearly if you have, as a patient, more control of your own little personal data website, essentially is what it is, then you can be the mediator of sharing. So that makes a lot of sense, that people can share. So if I go to that doctor, they don't have to wait. You can say, well, here I got it on my iPad. Take a look at that. So that is great. And I think more just sort of generally, kind of philosophically, it makes a lot of sense, because in healthcare, despite it being increasingly digitized, datafied over the last 20 or 30 years, the sort of poor relation has always been the patient, where they don't have sometimes the power to. In some countries, they do. Perhaps in rich American private healthcare organizations, where it's very consumer orientated and linked to billing, you might have much more access to your data. They may be more motivated to give you a customer service interface, but that hasn't been the same in public funded healthcare. And in a sense, the data has been owned and controlled by the organizations that develop it. And that's not that unusual, actually, from corporate management of data. But it's frustrating from the patient when they want to better understand their condition, look at their changes, manage their medications, communicate with their healthcare professionals, and avoid misinformation. Really important that they can get access. And plus, it's a sort of more of a democratic right in a state-funded healthcare system that's paid for through general taxation. We pay for it, we own in the NHS, and therefore we have a right to use it. So to have the data we're contributing, at least our own data. So there's that element of that democratic and self-management side, which is beneficial. And these things could potentially help, as could others. And the NHS app, you can get it on your phone. You can get access to your summary care record, summary health record in here if you want. But it wouldn't be the full thing, and you can't add lots of other things to it necessarily. But that's a possibility. So it's not just Solid that's going to provide this answer, but it's one way of looking at it. So that's another thing. But I think, and of course, the other side of it, of course, is this hope that with these personal data stores, as I said, they're evolutions of concepts that have been around for a while, and for some reason we haven't actually been able to deliver. But perhaps now doing it in a more secure way that allows for this federated learning is good, because it overcomes that question of, I manage all my data and you can never get to it, and therefore you can't do research or public health analytics, versus you own all my data and I can never get to it. There's some sort of middle ground where you, as the citizen, have more control, but at the same time, there may be a default setting whereby you can share anonymized data for purposes A, B, and C with stakeholders X, Y, and Z, but not with anybody else. The other thing that they are hoping to do, I think, as well, which is, again, fits with some other stuff that's been going on for a while, but is potentially very useful here and is being piloted in the NHS for certain conditions, is when you have a complex condition and you have all of your information together, you may be sharing not only lots of different bits of health data, but other social data and other sorts of data that are relevant to you and your wellness, and that you put together your, informal carers or whatever. So that is useful for you, but at the same time, you might want to buy commercial products and services or tools from the NHS App Store or wherever they happen to be, verified, reasonable tools that you could plug in using an API to your data and gives you a personalized information. It might be like a little concierge service, or it might be a symptom tracker that gives you advice or something like that. Or something linked to one of your diabetes monitors, for example. And that should be, the idea is easier to do with these new approaches, and takes some of the pressure away from the health system and all the burnout that is causing for doctors, and enables you to do it yourself. So those are some of the arguments in favor of it. And, in terms of the distributed data, in terms of the federated learning, that is actually... that remains to be seen how successful that is. But we have always had this challenge also when it comes to privacy and data control. There are the hawks and the doves, just as in any field, and the depends how you frame the hawks and the doves. But if you think of the hawks, the privacy hawks, they don't want you to have anything, and then the kind of total sharing everything for the public good side of things. There's been that polarization, and there's been some exploitation of consumers when they are too willing to share, because then sometimes third parties, take advantage, or there's an overreach by governments or health organizations into data for purposes other than those intended to benefit the individual or indeed the group. And those have really annoyed people. So whether this is going to solve that or not, I don't know, because having default settings can also based on trust to a large extent. And if you're trusting, you will open them up. And if you're not trusting, you may be suspicious of even the most benign pieces of data.
This might be a great, actually, where you're landed here now, I think this is a good place to go into the infodemic that is on your profile that you worked on and researched, because I feel that this lack of trust is quite related to this particular topic, right? People are being confused by, I would say, antagonistic players that are purposefully confusing them, and it is somewhat then becomes like an epidemic in a way, right? Could you speak more about this, and how does this work? How do these mechanisms work, and how does that interact with what you just spoke about with respect to trust and wanting to share your data with the NHS? Because if you have a conspiracy theory that the NHS is sort of in cahoots with, I don't know, the vaccination companies to track you with, there's all kinds of crazy stories out there with respect to that. And so how does that interact with that?
Yeah, I mean, they are, these things you're rightly saying are connected. And I think more to do with fundamental issues around trust in institutions. And, there are, extremist views whereby you don't trust anything that is associated with a government or a corporation, and you must do everything sort of on your own. I suppose you could then use some of those data stores to manage your own health, but you wouldn't necessarily be able to benefit from all the other things that are available. But in terms of the infodemic, that's a quite complex construct in the sense that it kind of evolved over the pandemic to take account of all forms of information that people are bombarded with and overloaded with during COVID. So they get too much information, and much of it's contradictory or confusing, and they have to kind of interpret it, and sometimes those interpretations are just wrong, and those wrong interpretations can get spread. At the same time, there's also, as you mentioned, malicious or calculated misinformation that's designed to confuse people or create fear or to undermine public health efforts like getting vaccinated. Imagine if you are a hostile state that would like to ensure that you have a competitive economic advantage to your neighboring country, which is debilitated by COVID or whatever it happens to be, then one successful way of going about it was to persuade the population not to take part in preventive health measures by creating a sense of fear and suspicion. Now, I'm not saying that went on, but that is certainly, the risk of some of this. But also there's the usual kind of money-related issue that people often that use these misinformation sites or develop this misinformation are in it for the money, either because they get lots of clicks per view and they can sell lots of airtime, or because they, as we've found in this case, the same bodies are associated with lots of other things that outrage people, like gun control or whatever. But they're very often linking it to something they're selling you, like a nutritional aid or some sort of medication that's false. And some of these, guys that led a lot of that anti-vax stuff in the USA in particular were coining it. They were making tons of money from selling products on their website. So, we really have to watch out for that. So the infodemic is a challenge. We're lucky to have the internet. We're lucky to have social media. We're lucky to be able to share information, and particularly in a time of a crisis and emergency when there may be not any evidence because there's not time to do the research. You need to work quickly. But at the same time, we have to manage those risks as well.
Yeah, that actually concerns me quite a lot, that, deep fakes and things like that are polluting the information. And you don't even really need deep fakes to go to this point, but this kind of misinformation pollutes the internet to such a degree that eventually it defeats the point of having it, right? It could get to that point if it gets too polluted.
Yeah, absolutely. And this is why it's important to have trustworthy sources that you can go to that are verified. And I think this is often one of the reasons why the troublemakers will try and undermine those trusted sources. So the World Health Organization, for example, has come in for a battering from some of these conspiracy theorists. Governments as well, the argument gets politicized. So I think that is why that happens. But we absolutely do need to have and in general, people will go to the most trusted sources first of all. What we do, I suppose, the other thing we need to do in the future, though, I think there's going to be quite a bit more of a challenge as we see these large language models and generative AI becoming more effective at developing persuasive communications. You could say to your chat GPT or your whatever version it is, as they seem to keep changing every day. The latest one is come for an announcement from China yesterday that they've got their own version. But you could pretty much say, write me a scientifically persuasive paper about how the government is trying to kill you by implanting you with microchips every time they give you a vaccination. And you could produce this automated thing based on pseudoscience and conspiracy theories. It would probably be very persuasive. Let's say you arm that with much more theory, which you don't have just now. So often it's just building on stuff that's out there already. It just grabs and recombines and finesses. But let's say you build it into theories, so theories of public health, persuasion and communication. And we know that there are bodies who actually have a long history in things like propaganda, who are very used to behavioral shaping. So let's say you were able to use all of the techniques of public health communication to make this particularly persuasive, then you could really run quite dangerous human-like persuasive campaigns in the future. And I think that's probably where we need to be focusing our attention next. Although in the meantime, we ought to be watching out for bodies like, for example, Elon Musk's blue tick verification scheme. Who is he blue ticking? You have to pay to blue tick. If you're just a good person, you may be an expert in public health. You don't get a blue tick unless you pay. So there's somebody else who's a bad actor and they decide to pay, they might get a blue tick. And how well is that being managed, for example? Again, I think we're wising up. And even Twitter's wising up to that, but there are incentives that are not
don't believe
perfect.
it. I think you have to buy in it a little bit. There has to be buy-in in such things. So you know that if you have a PhD or even a master's in science or something like this, and you're maybe you have some understanding of a subject, and then people can trust you. And now with this blue tick, there isn't really any process that is believable enough that why would that make you an expert, right? So it says, I think that's why people won't buy into it. I think you won't get buy into these things because you need a process to attain the PhD. And you have a very esteemed university giving you this PhD, then, that's a sort of a stamp by an authoritative institution. So that's, I think with these blue ticks, I don't know that will work. It's a little bit too artificial, I think. But I wanted to ask you a bit about the body, the Internet of Bodies, including brain to computer interfaces, and also perhaps with this data privacy in mind, because there's a lot of data clearly when you're doing that. Is there specific data that is different if you have that sort of interface from, say, if you have a iPhone, which is also a type of brain to computer interface, if you will, without, it's not the best interface, one could say. So maybe are these new interfaces that are directly from the brain to the computer, are they really that special? Is there data that is collected that is sort of special that could potentially impact privacy concerns in a specific way? Is that also true of other things that are included in this Internet of Body concept? What is your opinion on those things? What do you see there?
Well, I think the body is quite big. It has lots of points that can be digitized or influenced, and there are slightly different arguments, I guess, or propositions depending on what you're actually trying to do. For example, obviously, in a sense, our phones are already doing this to us. It's an embodiment of a technology in us. They essentially control our behavior and our minds, sometimes depending on what you're addicted to or what you rely on for your work or your management of your time or whatever it happens to be. So, and like driving a car that feels like part of your body after a while, you don't think about it. You've embodied those skills. Essentially, we've done that already. So they don't really need to implant us because they already have. But they're augmentation tools, support tools mostly. And the same is true with the more on-body and in-body technologies, from anything from things that just are cameras or motion detectors that sort of monitor where, let's say, an old person is moving. Are they getting up in the night? Are they wandering? Should someone be alerted to that? Have they turned on the kettle or the cooker and not turned it off? Those sorts of things, again, are monitoring our behavior, but also physically what we're doing. And those things are aligned. Behavior and what we do physically and what we're doing mentally is aligned. So that's already happening. And some of that is helpful. Some of it is just really creepy. Real dilemmas being had in healthcare, particularly in social care, about the ethics of monitoring people in their own homes, particularly as it becomes much more camera-based, and they're not going to have the right to privacy anymore because they're a bit older. Have they been told about this? Those are challenges that we face. But again, the data is quite simple. It's where are they? What are you doing? How often? Is it an unusual time? There may be an algorithm that says above this, call the daughter, above this, call the doctor, above this, call the ambulance. They're not that complicated. Then we get to the insidables, slightly different, or the kind of attachables, really. The wearables, again, have been tried for a while, kind of body area networks, sticky things that you put on yourself that can that can be actually quite helpful sometimes. Let's say you're rehabilitating after a serious injury or a stroke, and they have been used successfully to look at your gait. That's how successfully you walk, how normally you walk. And they can look at whether you are, or you've attached a prosthetic limb. Is it working properly, or is it going off to the side the whole time? Have you mastered it? Does your physiotherapist or your biomechanical engineer need to adjust something? So that is probably helpful, but again, very biometric, very that's perhaps very purposive. And you move on the inside then into your, digestible cameras, or your any form of implant, which is designed to it could be work in certain types of diabetes monitors, for example, that measure your blood sugar levels, or whatever it happens to be. And obviously there are innovators all the time trying to create other things that they can implant to you to detect more aspects of your body. But again, they tend to be very purposefully done, and the data will go to a certain place, and they're not kind of controlling your mind, but they're controlling sometimes the devices that help to, deliver the medicines that will optimize your wellness without you having to think too much about it. And some of that is very positive as well. Obviously, these things can go wrong. Same with heart implants and so on. And if you get into the brain implants, it's a bit more problematic, particularly where they are doing a bit more than monitoring your things like your alertness, and actually trying to introduce signals that will make you behave in a certain way. And some of that is very sensible and has ethical reasons behind it, particularly, let's say you've had a brain injury or a spinal injury, or you may have a particularly severe mental illness that requires very targeted treatments, or things that monitor your circadian rhythms or deliver more. So they can actually help, or you may be able to actually control the robots that are assisting you to eat your dinner, and you can just okay, then there's nothing to stop us being able to sort of telepathically manage some of these robots. And I think that is fairly normalized now. We're not doing it a lot, but it is something that you could do a lot with people who are paraplegic or something like that. So very sensible. The problematic side of it is when you get it, the risks of perhaps controlling people in ways that are things that they don't want to be controlled, or they take away their autonomy, and that is not necessary. It may be either something they think they desire, or that a company wishes them to do. For example, the early proposals from Elon Musk's Neuralink, he was talking about mass production of these things to put in people's brains so they could just look at the internet or do gaming. And you would literally drill something into your head to do that. I mean, they talk about I'm sure there was some of the zealots who really wanted to do that, but it certainly wouldn't be a mass production thing. The idea that there may be something, it was closing, getting rid of your privacy, you're actually inviting it into your head, is really quite alarming and dangerous. But as I said, some of that is already happening through social media. So those are the challenges. And you asked about, the data. There are supposedly thought-reading softwares that can interpret your brain waves and, see that you are looking at a picture of a cross rather than a circle, and that will appear. And increasingly, whether you're happy or whether you're sad, or whether you recognize something or don't recognize something. And, obviously that could be misused, but it's still quite experimental. But most of the data is fairly simple, but it does need regulated because of these perhaps futuristic Black Mirror type scenarios that one could quite easily see coming to fruition. And there is some merit to looking at science fiction movies and anticipating some of the things that could happen by doing that, even though they're very far away today.
Yeah, I feel like sometimes they don't have enough imagination, these writers these days. But I find that in the 70s and 80s there were some really interesting science fiction writers. But I feel that the narrative, for example, on AI hasn't changed very much in the face of actual AI developments. And I would really love to see some science fiction movies that are based on taking current developments to their extreme. And I haven't seen anything of that sort yet, of the sort that I would be interested in. For example, a person falling in love with a completely unconscious machine, but not knowing the difference, and then finding out over time that it's actually a machine. That would be really interesting. This difference between conscious things and not conscious things that is behaviorally maybe not distinguishable. Stuff like that. I would really love to see that in a science fiction movie. I haven't seen it, but I wanted to talk about a little bit about the profit motive as well in this, right? So a lot of these things are developed, a lot of the developments and innovations, actually most of them, some of them are developed on the government's dime, and as you said before, we pay for that, and I guess there's quite a bit of that in academia and public institutions. But there's a lot of work being done in for-profit organizations like Amazon and Google and the likes. And there is this idea of surveillance capitalism by Sublov, a scholar on the ethics of this. And I feel in the medical area, this has the potential to be particularly severe. And I wonder about that. I just wanted to ask you about that. Do you see this profit motive? Actually, is it driving good innovations? Is it driving the kind of innovations we need? Or, the most of, for example, in poor areas where people are dying of malaria and so on, is that solving that with the profit motive? Because I don't see it, right? Because when people can't pay for the cure, it's unlikely that it would be researched very much, right? And with this kind of motive, and is there enough of other motives going around that we are actually developing in the direction of greater human flourishing, rather than into eliminating male pattern baldness and things like that? I mean, I shouldn't speak about this because I don't have this problem, but maybe it would be very bad if I had it. I don't know, but I don't see it as a very particularly severe problem in the world. So I'm wondering, are we solving the right problems with this motive in mind?
And I think there's several things to separate. Are we innovating for better value? What do we mean by value? Are we innovating in order to improve the efficiency and effectiveness of public services so that we can use the money, we can spread the money further and reach more people, or be more effective in the medicines we deliver or the care that we provide? So there are certainly, innovations designed to do that, like electronic health records, for example, that are supposed to make things, or certain types of predictive algorithms for bed blocking or roster management that could help in that way, or certain types of automation technologies. So that's kind of adding value, but is also reducing costs. So it's adding value by reducing costs. You can also perhaps, add value by reducing costs by having better public health analytics, for example, and knowing where to target your resources, knowing which policies are going to have the biggest effect, biggest positive effect, because you can see it in the data. So there's all that sort of value there.
There's a specific
kind of.
There's something specific about measurement right there. I mean, even if you have lots of data, how you calculate progress from that data it has a huge impact. Is that right? Do you see that? Because I think it matters, right, how aggregated, for example, you are, or disaggregated, and how personalized you can make it. I'm just making a note. Do you see that?
So, I mean, there is that. We're talking mainly aggregated data for those big institutional uses. And then, of course, you've got adding value for the patient, and they are trying to improve their management of their own condition through these technologies, or their clinicians are able to more closely personalize the healthcare to their particular needs, and it may be even their genetics that could be there. That's a different kind of. And then there is on the other side, there is the developing of innovations to make money. So what is your motivation? Is your motivation to improve quality and efficiency, and saving and value comes that way? Or quality of life, saving and value comes that way? Or is it to make money? Now, the trouble is, in this field, where all of the venture capital goes is in the ones that are going to make money. Often they're designed purely to make money. And we see a lot of, it's actually endemic across the tech sectors, young graduates developing something with the sole aim that it will be bought by a bigger company and they'll be able to cash in and spend the rest of their life on YouTube. That's the extreme case. But you do get that. It's about the money. And also at the same time, you also get financially motivated health systems where it's about the money too. It's about how can we know the most about the patient so we can charge them the maximum amount we possibly can and minimize our exposure to risk as much as possible. So that's very linked to actuarial science as well. So I think where you come to think about what's the relationship between money, I think you asked, or financialization, if you like, and these healthcare innovations, it's a complex one. And there are many, good non-profit companies, but they don't have to be non-profit. They may be able to make an honest profit doing something that has a value. But we also a lot of hype-driven herd behavior, such as all the herd behavior into AI that we saw in the last few years that never came to anything. That may change now. We see a very different set of propositions emerging. We are really on the cusp of a major change, but no one really knows yet how to use this technology. And those use cases will manifest over the next few years, and there will be, people spending money and losing money, and other people will be getting rich. But ultimately, our benchmark needs to be how much value are we adding to the system and the public good and the patient well-being. But I don't know if that's answering your question.
That's asking
this difference between value and money.
Yeah, let me just ask a follow-up one that's a little bit more specific to, let's say, AWS, for example, is the biggest ecosystem right out there for the way in which patients are now served with this electronic way of serving people, specifically long distance medicine and so on. And so I'm wondering, is AWS and Google Cloud, are they providing good value, or are they? I know they are for-profit organizations, but they claim that they are doing important and useful research in the medical area. And I know DeepMind probably has. I've seen some papers that I admire quite a bit, but they operate under the profit motive. So there's always a little bit of an ambivalence there for me, because if you operate under this profit moment, can you serve two masters in a way? Can you make a good profit and also really serve the public good? Is that something that's happening in the medical area?
Well, often the kind of core business is about the making a profit, and it might be just by providing a service like a cloud service or a data, some kind of technology platform for which they get paid, or some services on top, cybersecurity, whatever. But they, often they're also doing some for good research, for good in inverted commas, or academic interest research that's good for their corporate reputation, but also allows them to experiment with other stuff that doesn't necessarily have a profit motive in mind. So even those big companies, it's not one thing or another. They're doing so many different things. So a lot of the work in DeepMind, for example, was not profitable for a long time. It was purely interest driven and with promise of a future, payoff, and they have come up with some very interesting results and innovations. So I think we can see that. In terms of corporate control, though, again, you talked about these big organizations like Amazon, and again, it partly depends on the health system that you work in. So a major driver for Amazon's move in this was to control they control so much of our buying and selling, was to control our buying and selling of medicines, really. Control pharmacies. They've now datafied things. They've made it easier for you to obtain pharmacy products online using their platform, and now they're bought out the actual pharmacy companies. And the next thing, and in parallel, is that you get to use the data from all of these buys and sells and outcomes that you've managed to bring together, and you're also trying to develop your own healthcare system on the side, to develop much more precise analytics that actually help you to better understand how health and disease work. The impact of certain medicines will help you to become a leader potentially in pharmaceutical innovation in the future. So the idea is that you capture more and more of these things, and they are able to build upon one another to create a sort of superborg of wonderfulness. Now, depending on who you speak to, some people think that's a good idea because Amazon's made things cheaper for them, they say, in terms of their products. But, we must always consider the other side. So just like I was having a conversation with someone yesterday, we're throwing away our cardboard boxes at the same time from Amazon. And just as Amazon maybe gives you your kettle or toaster for 20% less than you can buy it in the high street, you are also taking that 20%, not only you've saved it, but actually you're disposing of more rubbish that your taxes have to pay to have removed, and you've removed the shops in your street because they can't compete, which used to pay the taxes that help to subsidize your city. Now you've got to pay more. So have you really benefited? Or does it just seem like
that's
that?
A huge
and I
question,
suppose that is the thought when we are looking at the
with the healthcare, then you wonder, okay, what is the parallel scenario to the boxes in the case of if we can solve protein folding problems, for example. Let's say Amazon solves some protein folding problems and therefore helps with the curing of some disease, or they worked with Pfizer to produce faster vaccines and so on. And of course, they made a lot of money on that. And on those things, but is it not also true? So this is where I think sometimes maybe sometimes there is something to be said about this profit motive. It doesn't always work, but sometimes it seems to me, how could we be worse off if we understand protein folding problems, right? I think that is probably for the good of things, even though it's maybe produced entirely out of a profit motive. I don't know. I can't really see what.
I don't think it was the motive that drove that. I think it was DeepMind that did the protein folding piece, and I think it was just general to see if they could do it. No, I think there's going to be many innovations that are enabled by all of these technologies, and there are inevitably the biggest players with the most money and the most ability to lose money, the most willingness to risk their money on experimental and research-based projects. That's where probably a lot of that innovation is going to come from, as well as the universities who are essentially doing the same thing but at the state's expense. This is great. We can develop more effective and precise medicines. For example, we spend a fortune giving people medicines that are, excessive, that are not necessary and that sometimes are harmful. So actually getting that better would be, preferable. And likewise, understanding the need to tailor things to people's genetic profiles or lifestyles, you can use that data. What I was talking about in terms of the boxes is which is more very much conventional monopolism, which is more to do with the fact that the companies enabled by their kind of cheap service model and all of the analytics that surround it. Google's a data company, Amazon's a data company. they, but they also have the power to strategically know what to buy in our analog world. And that would include shops, it includes maybe pharmacists, it includes, in a sense, we become ultimately dependent on the same monolithic organization rather than this group of independent providers and government providers and so forth. So we do risk a dependency, and we have to have transparent and open public conversations about whether we're willing to do that because it offers us advantages. And if we are, then what rules and regulations and safeguards are going to be available to ensure that it's done in a way that is transparent and equitable and fair in terms of resources.
Absolutely. But I mean, the interesting thing, so I think that what I've read about the healthcare industry in particular with Amazon is that it turns out, I think, what is going on is that there's a lot of healthcare startups that are operating on top of Amazon, that are basically using Amazon services and then maybe adding some other scientific advance or something on top of it, but then buying Amazon services on one hand and then selling their own added value services downstream, right? So that there is this little cottage industry of small startups that innovate in very specific niches and then delivers those services, but there's this bigger, underlying Amazon or Google underneath that basically enables them to do that. What do you think of that? Is that not in some ways, I feel like in some ways Amazon is the high street and the shops are the startups, so it's, I don't know if that's the right way to think of it.
Yeah, that's fairly quite fair characterization. It's never going to be perfect, but close. I mean, again, these are why we have to have these public conversations, because it's not just a simply, right or wrong scenario. Obviously, we have created these infrastructures, these platforms on which lots of other things can happen. And there's nothing wrong with that. I mean, in this development of this latest AI in China, I was reading about, they're talking about it being a platform that's open to anyone that signs up in the future, and you build your own customized AI on top for whatever business requirement you happen to have. Now, but the question becomes, well, does everybody have to give money to the platform provider in order to do their innovation, in order to do their business? In other words, is there a taxation that is being levied by a platform provider that you cannot escape, because there is only one or three places, including the Microsoft, let's not forget them, platforms where you can do your business? And I feel it's the same with Microsoft. I've seen their cloud computing being used in projects. Free, supposedly for free, but then of course, who owns the data for all these scientific projects? Who gets control? Can you take it to another platform or not? Those questions are not always clear. And then of course, you move on to the post kind of friendly phase, as we've seen with Adobe and Microsoft, when you get to the point when you no longer own the documents you've created, or the PowerPoint slides you've made, all the videos you've recorded. You don't own them anymore. And if you stop paying your rent to the company, they can pretty much remove your access. So will that happen to all of innovation? Have we created a new form of corporate-led taxation? I suppose those are the sort of questions we perhaps need to ask. But on the other hand, we also need to encourage and support and monitor platforms that enable innovation to happen and that support interoperability and so forth, that we might not be able to do without them. Yeah,
no, it seems that way. I mean, Varoufakis calls this, Yanis Varoufakis, I'm not sure if you're familiar with him, he calls this the Techno-Feudalism, this stage that we're in now, because it seems that Google and Amazon have taken the role of the state without the democratic part, right? So we're silently taken out of our democracy by a takeover of the functions of the state by these corporations. So I see that's I can see that's also happening. It's a bit scary to me because we have these democratic ideals, and they don't seem to apply in innovation. Right? What gets innovated doesn't have anything to do with what we want to have innovated on, or what the public wants. Whether it is public money or private money, it turns out. Even the universities themselves are guided often by what is commercializable at the end of the day. Is that not true?
Well, it is true. There's been a real push over the last 15 years to commercialize everything that comes out of a university. And that is, sad in a sense. And also they're trying to encourage innovation in the society and get the best value for public funds. I understand that part. But there's also been a side of it which is resulted in things developed at the public expense by public servants being then monetized for private gain by a few individuals, which is, with some creaming off, of course, but it just seems wrong. And it's similar to the argument about most drugs in the USA have had, it's approved by the regulators in the USA. The vast majority were developed at public expense in universities, and then the outcome was taken off and monetized. And I think people are getting a bit wiser to this concept of value sharing. That is important, but that is certainly the stress. I've slightly lost the thread there. What were you saying before, asking about the universities?
No, I think that's on the thread. So basically, the idea that they are being funded by taxpayers' money, and we have this ideal of democracy. But what gets funded in terms of research and what gets done in terms of research and innovation isn't under democratic control, yet the money often comes from us, the taxpayer, right? So it feels to me that we are spinning in some silent way away from democracy toward this concept of techno-feudalism that Johannes Varoufakis was speaking about. And I guess this is a recurring theme in the show. Sorry.
I agree with you, and this feudalism is real, and again, there's been a concern with it for some time, and no action really being taken, unless it is social media. But I think, on the other hand, we have to be not too scared. In a sense, if you look back in history, it's almost like paper. The development of paper and pens, or the development of a machine loom for weaving fabric. They change things, but the question becomes: do you regulate, or do you? Is the threat the fact that there is now paper and pens that are all being produced by the same companies that are going around the world disrupting the way we do things? Or can we just say, we'll take that on board. And of course, you can go back to using vellum, which is like calf skin or whatever you wanted to use before, or, hand looms. That's fine. But the thing we need to still have to have our local control over is what is written on those pages. Once it's produced, where are the books? They don't own, they're no longer owned by the company that makes the paper. The beautiful fabrics aren't owned by the company that makes a loom. So, we have opportunities to manage things in our own countries without giving up on these other systems. The danger is when the systems then start to try and take over things that should be localized, or remove our capacity to control things at a local level. But I think a healthy synergy is possible if you have technologically aware policymakers and regulators.
Yeah, if they're not too slow, because if technology develops at a rapid speed, so I guess that brings us back to the first question in a way, these processes and how they're intertwined. Because if these technologies if the IP is hidden away and we don't know how the innovation happens and what they're innovating, and they're innovating extremely rapidly, it seems very difficult to keep that under regulatory control, it seems to me. What is your thought on that?
Yeah, I think as we always end up defaulting to principles-based approaches, which talk about things like transparency. And, often that comes down to trust as well. Are you able to understand what's taking place behind the scenes? Is it being shared with you? Which also, you can go down conspiracy theories about that as well. But at the same time, it's difficult. You need to be aware that actually you can't put your tin hat on the whole time, but at the same time, there are actually conspiracies going on, or at least some dark behaviors that need to be brought to light and need to be accountable.
Well, I wanted to ask you one more question about surgeons and virtual reality, or in general, virtual reality and its use cases in the medical field, because it came up in one episode, for example, on the metaverse. So we talked about surgeons being able to come into an active operation as if they were there when they're very far. For example, if you have a specialist from the US, say, and they want to participate in the surgery or in some kind of procedure that is going on in India, can they partake in that? Is that already happening? Is that going on? Is there that sort of use of the metaverse? Are you aware of that? And at the same time, training for surgeons. There's this idea that you could train people in rare medical procedures that never happen or very rarely happen. And when they happen, they might be it might be very important to have someone who's trained in it. But it's very difficult to train in it because it very rarely happens. So if that could be done in the VR system, what are your thoughts on those topics?
I'll just start with the one about the remote surgery. I think there's this has been tried even maybe 20 years ago. The first remote surgery, I think it was from Tokyo to someone in another country, happen. But if you look at our conversation we're having today, I can hear you having a few internet issues at various points, and you can probably hear that from me. And if I was on the surgeon's table, that would worry me. So I think that's how it's not the fact you can't necessarily do it, but can you do it in real time safely? I think maybe for collaborative, participative work, say you are a surgeon, a real top expert in a big US hospital, and you are doing some pro bono work to help surgeons in a low-income country that are less skilled, and you beam into the operation while they're doing it and help to guide them. Brilliant. And but actually getting your hands in the body may be a bit more risky, particularly with internet connections and so on. So I think there's lots of ways in which you can do these things. You don't have to actually physically do it. Where you might want to use these technologies is in the battlefield, and already are being used to some extent, and certainly experimented on to, not do it solely that remote person, but perhaps with another person that's just a soldier next to the body, helping them to deliver this. Or it could be a robot potentially in future that comes and sews up your patches or removes your bullet or whatever it happens to be. Or it could be a dangerous situation like a mine shaft or something like that. You can see these things working well, but I would say probably in terms of surgeries, more collaborative interventions and supportive interventions. In terms of patient development, VR though, that's another thing. And again, the internet's been full of images of this going on like it was a real thing for a long, long time, but it's not really been very real in many places. But there are cases, and increasingly so, where the markup of a patient prior to surgery can be done using augmented reality or virtual reality or holographic technologies. And you can begin to sort of do a walkthrough of the procedure you're going to do. Fantastic. I think that's really, really good. And being able to do your 3D imaging and project that on a hologram or something of the organ or the cancer that you're trying to remove. Brilliant. I think we'll see absolutely more and more of that, and I don't think we need to see it as a threat. It might be getting it wrong slightly, in which case the surgeon they'll find out when they get in there. So these things can't be done alone. But that, in theory, great. In terms of medical education, again, we need more doctors, and we haven't got the places to be able to, at universities, to be able to accommodate all the doctors that we need, and it's too costly. So, and at the same time, people don't want to donate their bodies anymore to lying on a slab and being experimented on. And we're anti-vivisection for animals, like people used to cut into animals. I did it myself at school. It was truly horrific that we had to do that for our learning. No, you could do that digitally using these simulations and haptic technologies as well. You can put into gloves. You've got your VR glasses. You may have other kinds of, sounds and smells or whatever it happened to be that could make it real and take us further on from what used to be virtual, like Second Life they used at University of Edinburgh 20 years ago. They were using Second Life in medical training and veterinary training into something which is actually much more real time. So I think for training purposes, for familiarization, also very good. And when it comes to other forms of surgery, there have been some challenges. For example, the training of more senior medical students to move on to surgical, robotic surgery has been a bit, there have been problems, for example, with some surgeons reporting that they had missed so much of their normal training in order to train on this specialized thing that when they were graduating or they got to the end of their training, they were good at that, but they couldn't do some basic stuff that all of their peers were doing. So making sure that you blend it appropriately and you don't sacrifice things is really important, and various other, flip sides as well. But it's definitely a trajectory we are going on, and not only to make things, the longer you have a patient open, the more things can go wrong. So the more you can plan in advance, the better, and the more pairs of eyes you can see on something, the better. And as we're in a national strike in the UK at the moment. All of the junior doctors are on strike, well, lots of them. And there's other parts of the workforce on strike, and there's other people leaving to go off to join other countries' health systems or join private companies. So it's reducing the workforce. And so we need to absolutely innovate and use these technologies as much as we can.
Wow, why is this happening? Why are these people leaving? Why is there so much?
Well, there are differences of opinion, but the main arguments they're putting forward are that they think they should be paid more, and also that their working conditions are very stressful and they're feeling undervalued. And I think the second part you can deal with if you're a bit more empathic and you are more sensible in how you treat people. But the first part is difficult in a publicly funded health system, because when the current demand is a 35% pay increase the junior doctors are asking, which could cost so much that the health service could collapse. And so obviously that's just a negotiating point. But, I think that's in general, and digital health can help us a bit in this as well. We need to recognize where difficulties come through inequality or feelings of it's the same in all these professions around Europe that are all having their strikes at the moment, this feeling of unfairness or not being appreciated. There are things that we can do that don't involve just throwing money at things, but involve being actually kind of more sensible and nicer about how we manage our employees. And that you can deal with a lot that way. But obviously the financial side is an issue too. If we want to sustain our health systems, because the medical profession is expensive. But at the same time, as we move towards a new generation of these augmentation tools that are technologically driven, we may then be able to release some of their clinicians' time and also serve more patients if some other tasks are. It's possible for other classes of healthcare professional who may be more abundant to deliver things that traditionally were delivered only by medical doctors. And that might spread the jam across the bread a little bit more successfully. And this is happening in low-income countries already. You get a community health worker that may have very little training. It's not a qualified healthcare professional, but using their mobile phones and video support and demonstrations and data exchange, they are able to deliver services that is equivalent to what a public health practitioner would do, or what a nurse would do, or in some cases what a doctor would do. You're augmenting all the time. So augmenting is about augmenting people, not just augmenting reality, as it were, so augmenting our skills. So we need to think about these things more carefully, as well as the softer aspects of healthcare, which aren't just to do with treating people as machines and just getting more work out of them. We actually have to make sure that the work they do is worthwhile, and that we're also aware of things like burnout, which can be a problem caused by electronic health records. If you believe the American literature, something that was designed to make people's lives easier was actually making them more burdensome. And you can't always get it right with technology. I was hearing about this concept, I can't remember the name of it recently, which is it's the idea that if you are hyper efficient and you reduce all of the administrative tasks from doctors, it sounds good because you want to get rid of the boring, soul-destroying administrative stuff and let them focus on the important, intellectually, challenging stuff around treating patients. But if you get rid of too much of it, they don't have any time to take their minds down and just recover from all of this cognitive stress, and you just ended up pumping them with the cognitive stress the whole time. So you have to. That's going to need calibration.
Yeah, that's a really big problem. I suppose you could just let them take their mind down completely without having to have this nuisance work and not having to. I mean, you should be able to give doctors a bit more breathing room from this and not just burden them even more. Exactly. Make them. Yeah, I see what you mean. Yeah, because if you treat people like machines, exactly, like you said, the danger with all of this automation is not only that you outsource somebody's job or that you are automating someone's job away, but I think actually maybe even worse, to make the person into a machine because of the way that machines are interoperating with these people, that they then, that essentially by introducing these machines, you're turning human work into that sort of similar optimized, hyper optimized kind of machine-like work. That's awful, really awful. Well, and I'm just would love to, if you could just tell the audience something that if you have something for them that they should keep, that they should take away from this discussion, it would be great if you could give them that, and also how they can keep in touch with you or your research if they so desire.
So probably, if I was to give them something to take away, is that we've gone through a series of developments over the last 30 years in the use of things like artificial intelligence, where we've had repeated hype cycles and phases of disappointment and disillusionment, and then stagnation, and then they started again. But I think we're probably sitting on the cusp of a real change. And in the future, we will see very soon much more assistive technology available to us to manage our own healthcare and other aspects of our lives in a much more human-like way that we have not had before. And we're going to see quite a bit of change in the way we interact with health services, because we'll be able to do a lot more by ourselves, aided by these technologies, and likewise our doctors and other professionals will be able to perhaps improve some of the things that they're doing as well as all of the background innovations that are developing the drugs and services in a more conventional innovation setting. So we're going to see change, but ultimately, in the end of the day, trust is critical and human interaction is critical. And healthcare is called care for a reason. Someone has got to care about you. And we absolutely must not just rush towards automation, hoping a robot is going to be that caring person. It is all about enhancing services and really making our lives easier. And, for which we'll also have to have public and policy conversations about what are the boundaries between what is okay and not okay, and keep a close eye on that and do it regularly.
So how could people keep in touch with you? And if they're interested in your research, follow up on our discussion and look into what you do more in detail.
Sure. You can follow up with me either on email, which is claudia.pagliari@ed.ac.uk, or follow me on social media on LinkedIn or Twitter, where my handle is @ capital E, small e, capital H, capital R, capital N. Earn. I'm sorry about that, but it started as Edinburgh eHealth Research Network, and then it became me, and then I got stuck with the handle. I will change it eventually, but you find me just with a search, and I'd be very happy to hear from anyone who would like to continue the conversation.
This show is published every Wednesday at 10 a.m. London time, at 5 a.m. on the East Coast, and 2 a.m. in Los Angeles on the West Coast. Please leave your comments and let us know what you like and what you don't like in the show, what you would like to see coming on the show. Please give us your thumbs up on episodes that you like, and let us know when you don't like something. Next week, I will be meeting with Srijit Panja, and we will be speaking about brain-inspired artificial intelligence.
There is some more priority, importance, focus being stressed on AGI, artificial general intelligence. Also, the recent paper coming from Dr. Jeffrey Hinton on feed-forward neural networks, that's actually a very, very incredible step towards actually moving from back propagation towards how actually brain works.